حط البرزنتيشن اهو كلنا جاهزين. We'll start now the session. We are going back to basic science, physiology and pathology and anatomy. We are going to tackle the problem, pediatricians and neurosurgeon hardships or challenges. And the most important challenge is hydrocephalus. I'll start with introduction.
السلام عليكم. إن شاء الله نبتدي السيشن الثانية Pediatric Neurosurgical Patient The Challenge. أولاً بحب أشكر اللجنة المنظمة على دعوتي لحضور المؤتمر ورئاسة الجلسة. ونبدأ أول presentation Pediatrician and Neurosurgeon Hardship by Professor Sahar Hassanein, Professor of Pediatric and Neuropediatric. بس تفضلي يا دكتورة سحر.
Okay. We'll start with the daily problem of hydrocephalus. This is the scene. All are neurosurgeons. I'm the only pediatrician or neuropediatrician among them. Okay. What is the daily problem we face? We have neonatologists here. We have fever hospital specialists. And we have pediatricians, we have different specialties, and of course, pediatric neurology. We have to highlight the importance of anticipation and early diagnosis of hydrocephalus and to find out a solution for prevention. Prevention is much more better. We all know about the hydrocephalus. It is increase in CSF volume inside the ventricular system, which will lead to, might be associated with malformations or neural tube defects. And the gold standard, or what was used to be a gold standard of management, the ventricular peritoneal shunt or tubing. The presentation is variable, could be non-specific at all, and I think we have different presentation. Drowsiness and the subconscious is emergency, and you have to perform neuroimaging, Dr. Khaled, in any child with the subconscious. Please, emergency. Headache, vomiting, irritability, high-pitched cry can occur due to any disease. In the neonatology, we have the sepsis, neonatal sepsis, can present the same presentation. Is it okay? The classic presentation in infants, progressive enlargement of the head circumference and tense bulging anterior fontanelle. In the NICU, you have these cases. Sunsetting appearance and dilated veins. This is a clinical or classic. We don't want to reach this stage. This is historical now. The presence of, in older children, the papilledema, the sixth nerve palsy, the vomiting, and increased intracranial tension. Presence of seizure, it is non-specific presentation. Presence of tachycardia, bradycardia, mottled skin. Again, it will complicate the picture, and sometimes the neurosurgeon send us the child with a shunt and to treat sepsis, and he is actually a shunt problem. The burden of hydrocephalus and BB shunts. Pediatric hydrocephalus is one of the most common neurosurgical treatable cause of disease. Factors lead to delayed presentation to medical care depends on the, in Africa differs from other countries. The etiology differs according to the country. We have intraventricular hemorrhage and prematurity, congenital causes in the developed countries, and the post-infectious hydrocephalus in the developing countries, which we are situated in Africa. So we are going to talk about the hardship in hydrocephalus diagnosis and management. We have a patient who will be treated acutely, surgically, and at the same time, he will need a longitudinal management. a lifelong shunt-dependent life. To complicate the problem, in both infectious cases, we might have the encysted hydrocephalus, which is difficult to treat because one of these cysts will press on the other, even in the presence of the shunt. The shunt complications are well known for all. Professor Hassanein is our neurosurgeon, and he started a registry for hydrocephalus in Egypt, I think 10 years ago. And this, I took this result from him. The post-infective causes, we have 23% of the registry and 29% the Arnold-Chiari malformation. We have a very large number presenting to the maternity hospital to deliver with malformations. We have daily 2 or 3 cases with meningomyelocele. Is it okay, Dr. Hassan? Daily, on daily basis, we refer cases with hydrocephalus, meningomyelocele, Arnold-Chiari, and we don't have the capacity to treat them. 20% congenital aqueductal stenosis, 12% post-hemorrhagic hydrocephalus. Again, the source is the NICU with intraventricular hemorrhage due to prematurity. The tumor-related is just 8% of the cases. It's very low in contrary to the other reported numbers. Now, if I have a 45 days NICU graduate, he spent 30 days of his life inside the NICU, and the mother came to me because of the progressive. She noticed that his head is enlarging, and it should be noted by the NICU during graduation from the NICU that he should follow his occipitofrontal circumference weekly at least. And this is his CT scan. And I'll let Dr. Hassan to tell us how we are going to manage this case. Before we can a VB shunt be considered the gold standard to treat pediatric hydrocephalus? Dr. Hassan, you will answer this question. We have a good communication with the neurosurgery and the pediatric, imaging department and the fever hospital. We need to hear the different perspectives. Hagar will present another case, and then we will continue after that. Okay.
إن شاء الله نكمل مع الدكتورة سحر. I have the pleasure to introduce Dr. Hagar. She will talk about the common presentation of the rare disease.
I am going to present a common presentation of a rare disease. A 4-year-old male patient who was developmentally normal till 2021, patient developed persistent vomiting. He received medications without improvement. 3 months later, patient did CT brain, which showed hydrocephalus, and VB shunt was inserted. And this is the CT brain before shunt insertion. In 6/2021, shunt was inserted, and this is CT brain after shunt insertion. In 6/2022, patient developed multiple attacks of seizures. Some was febrile and some was afebrile. 6 months later, in 1/2023, patient developed uncontrolled seizures. Upon them, he was admitted in PICU and shunt was removed. In PICU, CSF was withdrawn. It showed high proteins, viral, bacterial, fungal panel were negative. IVIG and solimidrol were given. Shunt was removed and the patient regained his baseline consciousness. 1 week later, patient readmitted in PICU in status epilepticus, intubated, convulsions were controlled, but he didn't regain his baseline consciousness. Patient wasn't recognized her mother not interactive, and lost her own motor function and cognitive function as well. CSF was measured several times and it was normal, and all parameters were normal except for high proteins, and they were double the upper limit. The most striking thing in MRI brain is present cystic like nodular lesions, nodular thickening, and it was detected as source of infection that may be cystosarcosis. So extensive infection workup was done, including cultures for mycobacterium, fungal, and viral cultures, and they were all negative.